Welcome to another video series on the topic of microsocial determinants of health. I'm Doug Nussman, head of sales at Montoux in North America. With me today is Mike Hughes, subject matter expert. And in this session, we're going to talk a little about this concept and how it relates to the clinical world. So Mike, do you think that the clinical world is embracing the microsocial determinants concept?
Yeah, I definitely think they're curious about it in general, but I don't see a lot of it, at least in the employer health space. Generally speaking, people don't stay on insurance enough in their pre-Medicare days for insurers to make deep investments in long-term relational care and to look at all the non-clinical things that impact your health outcomes, both the macrosocial determinants and the microsocial determinants. We do see it within care management programs in specialized areas like Medicaid, long-term services and supports, and dual eligible Medicare, Medicaid programs. These patients are a lot more affected by things like food insecurity, transport problems, and access to care. The macrosocial determinants, which, when improved, can make a big difference in health outcomes. When we look at the microsocial determinants, the individual influencers on health, like the state of the home, functional ability, presence and quality of family caregivers, we're seeing a growing interest with providers that are incentivized under value-based contracts. So programs where they get bonuses if they reduce hospitalizations, or programs where they get a fixed amount of money to take care of somebody for the year. And if they can meet quality standards and provide care for less than that amount, they keep the difference. Yeah.
So that's interesting. I guess anyone that's doing this type of care is making a big investment in microsocial determinants of health. Is that right?
Well, I definitely think they will be, but value-based care is new and it's definitely not at scale yet. Making the shift from fee-for-service to value-based means fixing clinical care coordination first and understanding how to really proactive and in a proactive manner manage clinical conditions over time. Historically, those types of things were not taught a lot in medical school. They also want to know that addressing microsocial determinants will pay off for them. So anyone that's seen the effectiveness within the Medicaid long-term services and supports programs knows that that's true, and anybody in the home care industry also knows it's true. And I think we're seeing the payoff first in these hospital readmission reduction programs, because hospitalizations are such a big part of the Medicare budget, and because the vast majority of rehospitalizations are avoidable and caused by microsocial determinants. Programs to reduce them, by addressing risk around microsocial determinants, show efficacy when the ER visits go down. And then historically, these programs, you see combinations of improved care coordination and caregiver education and training. Maybe they provide more home care, maybe they're providing home repair in the home, pharmaceutical delivery, things like that. Basically bundles of services to keep people at home when they return from the hospital. Again, each of them do show efficacy. I think that because they're a bundle, it's tough to find out which part of those interventions on their own may be over-indexing in terms of ROI. And I think that next phase of discovery is important in order for programs to be more scalable. But the good news is that we're getting more and more insights on what works better than most. And it's led to even more experimentation, especially in the Medicare Advantage world with these supplemental benefits. We'll see how things like the exercise programs and pest control and transport, we'll see how they impact hospitalization rates and move risk in their books.
That's interesting. So would you say microsocial determinants of health is largely non-clinical?
Yeah, it's generally classified as non-clinical information, but it is relational to the clinical world. So because behaviors are a big part of it. And it shows up in a big way when we look at one's ability to manage your own health condition, what we call health literacy. So this can be anything from understanding what contributes to your clinical risk, to your ability to take your medications and take them properly. Importantly, it also includes the quality of the food you eat and how much water you drink. Hydration gets more and more important as we get into our 80s and 90s.
So it sounds like this has a lot to do with behavior.
Yeah, behavior and motivation. And that also comes with being well educated on your condition and tying your adherence to that treatment to meaningful goals in your life. And this relates to another concept that's growing in popularity, this concept of patient-centered care.
So that's interesting. Can you touch a little bit more on what exactly is patient-centered care, please?
Yeah, well, generally it's providing care that respects and is responsive to individual preferences of the patient, their needs and their values, and ensuring that those values guide clinical decisions. In fact, whether you're entering into a clinical treatment program or entering into home care, I think the two most important questions that anybody should ask that person who's receiving the care is, what do you want to do? And what do you want to be able to do? And studies show that when a patient is engaged like that, they do become more health literate. And in fact, I remember one study that showed that patients aged 65 and older are the most health illiterate group out there. And I don't pretend myself to be literate in any sense, even though I'm kind of in the industry. I mean, I go in for an appointment, somebody puts a blood pressure cuff on my arm. They say it's 120 something over 80 something. I say, is that good? And they say, yep, it's good. And then the conversation kind of ends from there. And I still really don't have a sense of what that relates to. Embarrassing to say. But here's the thing. When people age 65 and over are literate about their health conditions, they're the most adherent age group out there. So I think that making the move in that respect can go a long way towards improving health outcomes.
It's real interesting. It seems like we all have a little bit of work to do. And we really appreciate you sharing these thoughts with us. So to continue the conversation, please feel free to reach out to me or Mike directly.